The key markers that we need to use before treatment, I would say frontline, is IGHV mutational status and TP53 alteration. TP53 alteration meaning 17p deletion and TP53 mutation. And I think that you can get IGHV status once for all because it's not going to move, but TP53 is really accumulating with different lines of treatment, and we really need to determine TP53 status at each line of treatment. And I think it's important because it's an important prognostic factor, and it helps choosing also between BTK inhibitors and venetoclax-based therapy. Concerning our patients in CLL, well, first the patient comes and we make the diagnosis with the cytometry, and usually I have the patient come back quickly to explain the diagnosis and explain that for most of the patients that I'm not going to treat them now, and and then I propose to the patient to have some prognostic markers done, and at that point I think that the important one is IGHV mutational status, because that's the time when it is going to help you follow the patient. If the patient is IGHV mutated, you know that he might not need any treatment, and that you might follow him just without treating him. If the patient is unmutated, you know that ultimately he will need to be treated, even if it's in 4 or 5 years. But that's something that helps the patient understanding his disease and getting prepared to the treatment. And then, before frontline therapy, as I just said before, you absolutely need to have TP53 status. And in my center, we also have NGS testing for the more frequently mutated genes, because we are doing research on it, but it's not mandatory at the time. But I think that it is going to help us get to more personalized therapy.